briefly some thoughts about OCD. And it's an interesting topic because it affects so many people. Really, in the United States, well, as of probably 1990, we had about 2.1 million people affected by OCD. And when you think, well, we're in a place of, what, 300 million, it doesn't seem like a lot. However, everyone knows roughly how many people, and how many people do you live with, and how many people are children or parents. So now that 2.1 million actually exponentially increases the number of affected people. When you talk about costs in healthcare alone, we're spending roughly about $8.4 billion on OCD behaviors, consequences, etc., in terms of mental health. And that's really about 5% of the budget, the total budget. It's about $147 billion that's spent across the spectrum of mental health issues in this country. So it actually is very significant. And if nothing else, the fact is that if there's one person in your life, or if you're that person, there is no price tag on what it is that OCD does and how it affects your existence. It's a tremendous, tremendous burden. Now, there are ranges, as we all know, really sort of a spectrum of OCD-type behaviors. Some are very, very beneficial. Some help us do kind of the things that we do. If we're just a little bit OCD about our schedules, our timing, our paperwork, we become pretty much one of those great corporate executives, okay? Or one of those great individual entrepreneurs, or individuals who bear a lot of financial or paperwork responsibility. Organized individuals, lovely little trait to have. What happens when our behaviors kind of shift to the extreme of the spectrum? Now we tend to become more incapacitated. We can't do our jobs properly. We can't do much of anything. Now, when that translates into the home environment, I can't tell you how many spouses I know who've said, well, you know, my husband just likes to really line up all the glasses along the edge of the counter, and that's where he likes it. Or, gosh, my wife likes things arranged this way, and if I move it, she has a fit. That's no big problem, okay, on average. We accept them as quirks, we always say, with regard to our families. But when it becomes such that, well, now I'm seeing that I can't move in this direction, or I can't move in that direction without causing a major problem, now that's disruptive to the family dynamic. When we look at disorders like autism, for example, autistic children actually have OCD-type symptomatologies because they become extremely rooted in what is regimented behavior, and it has to be exactly the same way every single time. If any of you have ever heard of or seen an autistic child traveling in the car, if their parents drive down the wrong street on the way home, they have a fit. If the parents drive down a path they're not familiar with, they have a fit. It's horrifically challenging and difficult to deal with this type of a condition. Now, typically I don't put OCD in the same category as autism for a variety of reasons, but that's another issue. But when we're looking or talking about these types of behaviors, it becomes very critical to examine where there's similarities and where there are differences amongst the spectrum of disorders, because they can always play a role in that spectrum. So, when we look at OCD now, let's kind of talk about really some of the more common symptomatologies or common difficulties. Where does it become helpful and where does it become a hindrance? The real hindrance comes into play when you're simply no longer functional, when you're to the point where you just can't do any more. One of the favorite TV shows out these days is Hoarders. And quite honestly, I'm probably a little bit OCD about not watching these types of programs because I find them so extreme in the cases they choose. But isn't that exactly what we in this profession and in healthcare are really looking at? Okay, we're looking at how do these tendencies translate into major problems or issues. For some people, it may be that we just collect every single newspaper since 1923 and we don't throw them away. And so our homes basically look like big giant paper factories and we can't move or sit around in them. For other individuals, it may be, well, you know, I've just got to count every single little tiny dot in every single one of these little squares right above us, and I'm not going to be happy until that's done. So we're doing that all night. Or we don't sleep, or it moves into these extreme patterns. One of the things that's very interesting is that if we look at traditional medicine, what we see is that we're really not sure what OCD is in terms of its causes, in terms of, therefore, its treatments. We do some decent guesswork, maybe, maybe not, with OCD in terms of using SSRIs, that is, medications that allow you to have more serotonin on board as a first-line therapy. And then there are cognitive behavioral therapies that are also used in the treatment of OCD, and a variety of other things. Well, my question still revolves around, if you're not really sure what it is or exactly what's causing it, how do you effectively treat it? In a way, we're kind of playing a guessing game. We're hopeful that we're going to take a shotgun, point it at this condition, and something we do is going to work out right. Okay, that's not exactly what we call hardcore science. That's more hardcore guesswork. But in all fairness to the community at large, we work with what it is we know, and we try to do what we can, trying to help conditions that are very complicated. My old residency surgery attending used to say, you know what, Albert? The eyes can only see what the mind knows. And so what the mind does not know, the eyes cannot see. We're talking about a particular case and why people get certain things misdiagnosed. Well, if you're only exposed to a certain understanding of a condition, that's all you're going to know. I want to fast forward to today and what we know now. What we're seeing is that a lot of conditions are rooted in biochemical imbalances. When we look at conditions like OCD, when we look at conditions like ADHD, autism, anxiety, depression, schizophrenia, bipolar disorder, a lot of these disorders have some components of biochemical aberrations involved. Why is that even important? Because I want to share with you, what the definition of a psychiatric disorder is in medicine. When you have tested every single thing you can think of for a given patient with a symptom, and you've come up with nothing, well, now it's a psychiatric condition. Okay. So by process of elimination, there you go. So we'll check thyroid hormones, we'll check neurotransmitters, we'll check all sorts of things, and if everything is normal, but you're still anxious, well, now you're psychiatric. So now we open up our wonderful manual of psychiatric meds, and we decide, well, we've got a choice of about 30 or 40 meds that are designed to treat anxiety. Let's pick one. And isn't the first thing we usually say, let's try you on these medications and see what happens? Well, translation, we're not really sure. We hope this is going to work, and if not, we've got about 40 other medications that we'll choose to try to do the job for you. That's not exactly what I call exact science. Okay, that is guesswork. And anyone who knows me will tell you I'm one of the biggest skeptics out there. Our folks here have heard me say that a million times, and that's because I like to have evidence, and I like to have a realistic assessment before looking to treat a patient. I'm not here to guess. If I've got to guess, my best guess is to send you somewhere else, okay, and notably probably to Mayo Clinic for those people who are going to bring in swarms of individuals and not just one person to evaluate and try to treat you, because their science should be better than what we're working with. So with that understanding, what we look at here and what we look at in our field of what we call orthomolecular medicine is actually trying to find biochemical imbalances that are the key to the conditions that we've seen diagnosed by traditional medicine, in this case, for example, OCD. Now, most places you go will probably tell you, gosh, OCD, there's no test for OCD. And while that may be true, the question is, what biochemical imbalances do we know produce OCD-type symptoms? Okay, now that we do know about. So, by definition, if we can find a test that reveals an imbalance or condition that can be addressed or treated with success and removal of symptoms, we no longer carry a psychiatric diagnosis. Okay. So that's the piece I want you to remember. All that verbiage boiling down to this. Can you test it? Does it show up? And can you treat it? No longer psychiatric diagnosis. Now, that's all semantics and so forth for those of us who are in the field. But the real problem is, I don't care about this or that. I just want to know if I can get better. That's what the patient, that's what the family members, that's what everyone around wants to know. What we've seen is that this concept we call methylation or methylation disorders, very, very, very prominent in the study of OCD in particular. Okay. What we're seeing is that individuals who have very few what we call methyl groups, the undermethylated individuals, have an incapacity to sort of activate or inhibit various enzymes, neurotransmitters, or hormones. So when we look at neurotransmitters, for example, if you've got norepinephrine or epinephrine, and you've got it on high gear because you know what, you've been chased by a bear, okay? Now you get away from the bear, but 2 hours later, you're still anxious. You're still sort of in that fight or flight mode. Well, there's a reason for that. And sometimes the reason is that you don't have the appropriate methyl groups to actually turn off that neurotransmitter. That's why we don't test neurotransmitter levels, because we know there is something else that's in charge, that's affecting whether or not that neurotransmitter is actually working or not working. So you can test and find serotonin levels are normal, you can find dopamine levels normal, you can find all sorts of normal levels, but yet the patient still has a challenge or a difficulty from a symptom perspective. Well, the question is why? Well, here's one of the answers we found. If you don't have enough methyl, you can't turn off those neurotransmitters, so you're still stuck in that fight or flight mode when you shouldn't be, which means you're still anxious or have inner tension. Many patients complain about anxiety, that inner tension. I don't feel comfortable. It's just not right. And you've checked the thyroid, you've checked all sorts of elements, and it's still there. Well, part of the reason is actually because you don't have the appropriate methyl groups to turn off the neurotransmitter that's present. In other conditions, where, for example, we use a lot of SSRIs, we're looking because we want to try to increase the amount of serotonin that's present in the system. Well, you can have normal amounts of serotonin, but if you don't activate the serotonin, it doesn't do you any good. But you know what happens when you turn on, or excuse me, when you test for those levels? They're normal. And the doctor then thinks, or the practitioner thinks, well, your serotonin levels were normal, so that's not the problem. Well, take one step back from actual neurotransmitter levels and look at those things that influence neurotransmitter activity. Okay, and that's the key piece that we're looking at. So when we're talking about OCD, what we've seen is that in the extreme side of methylation, or under methylation, I should say, individuals have these OCD type tendencies. They become unable to push the off button. That's the way to simply kind of approach it. And once again, individuals who oftentimes are undermethylated, well, they have perfectionistic tendencies. But what is a perfectionistic tendency in its extreme? It becomes obsessive, and it can become compulsive. Okay? So now we're talking about individuals who on one hand will really be sort of normal and functioning. Pushed to the extreme, their functionality is extremely compromised. So the question is here now, understanding and seeing that one element to this whole process of OCD evaluation is to look at the methylation aspect, to evaluate it and to see where a patient lies. This can be done with testing, by the way. Looking at a histamine test is actually a great way to evaluate whether or not somebody who has an OCD type tendency may be an undermethylator, a normal methylator, or an overmethylator. Now, most of the time, these folks are almost 85 to 95% undermethylators. Okay. Now, let me just share with you a little bit about this histamine test. Histamine, you've all heard of it, with regard to allergies, with regard to rhinorrhea, sinusitis, Histamine is a reactant in the system to an exposure that causes a response chemically mediated in the blood and the serum that produces multiple reactions throughout the body. Okay. Histamine in the brain, however, is a neurotransmitter. So when you have an allergic response, histamine just doesn't happen in your gut or in the eyes or in the nose. It's actually having a neurotransmitter effect in the brain as well. Okay. The difference is that it affects a different receptor site. So what is a receptor? A receptor is the welcome wagon for any neurotransmitter, any hormone that you've got in your system. There are receptors for serotonin, receptors for dopamine, receptors for everything, it seems. Histamine also has a receptor in the brain, the H1 receptor, but it's different from the one in the rest of the body and in the gut. What do you do when you've got an upset stomach, acid indigestion? You take a Zantac, you take something along those lines that affects basically the histamine in the gut. Now that's a different receptor site. That's the H2 receptor. Okay, it does not affect the H1 receptor. Okay, so in order to affect the H1 receptor, what you do is you actually change the histamine, and it will attach itself to the H1 receptor in the brain, leading to an effect separate and distinct from that in the gut. Here's the fallacy. Here's the challenge. When you test for histamine, though, it's not specific for the brain or the gut. It's specific for histamine, period. Okay. But that histamine level gives you information. The relationship is that histamine actually suppresses or lowers methyl. And methyl actually suppresses or lowers histamine. So we have an inverse relationship. It's like a teeter-totter. Remember those days back in the playground when you're on the teeter-totter and you say, okay, you go down and you go up? That's what histamine and methyl behave like. So when we do testing, an undermethylator is seen by our clinical testing as having high levels of histamine. An overmethylator, someone with high amounts of methyl, is seen as having low histamine. And the proportions are always like this. A normal person, a normal methylator, has typically normal levels of histamine. Okay. Some of the challenges with the test: if you are on antihistaminic medication, it can artificially suppress this particular test. But we know, and that's why we do these long sessions with any given patient. We talk a lot about medications that are being used and so forth, because we take that into account when we see the test results. So we adjust for that. But looking at the methylation is absolutely key in determining if this is definitely, or at least most likely, an undermethylator who's present. Why do we go through any of this to begin with? Well, because medicine says you really shouldn't do a test unless you're able to treat it. Okay? So if you do something that's a test and you find something wrong, well, we're not going to say you should never, but if you're looking for cancer, you definitely want to do a test to make sure you can find it. The patient needs to know. But on the other hand, if you do something that's a chemical test, people ask, well, why are you doing it? I say, well, I don't know. That's not an acceptable answer. Okay? You must know why you're ordering it, and the key here is that you order tests because you've got a strong belief that the test is going to confirm or deny your hypothesis. Okay? What I'm sharing with you is that the very principles we use in our orthomolecular approach are the same principles that are used in traditional medicine. There is no difference relative to the principle. Okay? And that's key because many people who really don't understand orthomolecular medicine will sit back and say, oh, you're doing that stuff with nutrients. And say, well, what stuff are you talking about? Well, you do that nutrition stuff, you do that homeopathy. I say, no, we don't do that here at Mensah Medical. What we do is we use a scientific approach that is time-tested, that is tested with objective evidence, and then we look at the subjective perception by the patient. And we put those things together to come up with our hypothesis about what is wrong, and we use it to treat. And then I kind of sit back and say, isn't that what we do in regular medicine? I know it is because I'm a regular doctor too. Okay? We treat colds, we treat flus, we treat pneumonia in our other world. And then we look at methylation disorders, we look at high copper levels, we look at a variety of things that come into play. Okay? Now, I'm not saying methylation is the only aspect with regard to these imbalances that can produce OCD-type behaviors. The anxiety component could be related to high copper. It could be related to low levels of zinc. And why do I say that? Because high copper, we know, pushes the dopamine pathway to produce more norepinephrine, a very stimulatory neurotransmitter. Okay? Low zinc actually makes it very difficult to make serotonin, our well-being neurotransmitter. Okay, which means that those elements that are more excitatory in nature take over in the balance of your mental health. Okay. So we look at all those variables. We do objective testing. We look at subjective principles, and then we treat the results based upon what it is we find. Okay. So that's kind of how we look at this. We've actually had some very interesting advances over the course of time. Back in the old days, and the old days now is about 4 or 5 years, back in the old days, when a patient came in to talk to us, and they would say, you know, I'm here because of OCD. Do you treat OCD? And I would go, yeah, we do. And it was harder for me to accept an OCD patient coming than it was for me to see a schizophrenic patient. By the way, schizophrenic patients do really, really well with our modalities. That was because we knew that the issue regarding histamine was more likely the key and under methylation. And to treat a methylation disorder that's typically under the category of OCD meant convincing a patient that they had to stick with a regimen for almost a year before they might actually begin to start to see improvements. How many of us are going to sit back for a year and do anything without any kind of result? You're going to go work for a year without any money? It's like, no, in a year you'll get the results you're looking for. Very difficult. Not that it wasn't effective, it just took longer. Well, then one day, Dr. William Walsh, who is our mentor friend and still kind of functions as our research authority, he and a colleague who taught us a tremendous amount of neurochemistry brought forth this idea that was actually found in the American Journal of Psychiatry. Okay? And it involved a receptor in the brain. And this particular receptor was now being influenced by elements like D-cycloserine. And we found this to be very, very interesting. The American Journal of Psychiatry, talking about a nutrient supplement? Is this the same hardcore group of stodgy scientists that really required proof and pharmaceuticals to get the job done? Well, in all honesty, D-cycloserine is a variant of serine, okay, which is the amino acid that we're talking about. I thought it was great because they're looking into what it is that we talk about, which they deny usually has any benefit. But here it is sitting in their own journal. What did this thing do? According to the reports, it showed that you could actually affect individuals with OCD and produce change in roughly about 50% of the population that was significant and long-lasting by the use of this particular element, this D-cycloserine. And with it came long-lasting results. And I said, wow, that sounds really interesting. But only 50%? And then our good mentor corrected me. He said 50% of all the symptoms, meaning every 50% of the population, 1 and 2, had total relief. Okay? The other percentage had partial or significant relief. And I said, well, that's amazing. So how much time are we talking about? Well, according to the journal, 2 or 3 months. And I said, no way. You've got to be kidding me. Remember, we were used to seeing a time course on a level of 1 to 2 years. So we had a patient that came in, and we said, this is a good candidate to try this stuff. So I talked to my partner, Dr. Judith Bowman. I said, Judy, let's put this patient on D-cycloserine. So we did that. And a few months later, unfortunately, there was some domestic discord, but we asked the mother how her son was doing. And Dr. Bowman said to me, yeah, she says the son is doing really well. I said, well, great. What does that mean? According to our research, according to our studies, we've got 7 or 8 different parameters that are being affected or not being affected. And she said, oh, he's doing really well. I said, no. What does that mean? What is well? She said, well, the symptoms are gone. And my next thing was, well, which symptoms were gone? He said, all the symptoms are gone. I said, excuse me? What did you say? Skeptic in me. I said, did you ask the mother about this symptom, that symptom, that symptom, that symptom, and that symptom? She said, yes. I said, you mean to tell me all of this kid's symptoms were gone in 2 months. Even though I have a hard time believing it when I say it. But that's exactly what happened. And I got really excited because we now went from that challenging 1 to 2 year realm to literally 2 months. But the skeptic in me said, let's get this straight now. This is our empirical trial. This is what we are seeing. Let's test a few more patients. So sure enough, testing a few more patients and treating them, we saw that what was going on in the journals and the journal reports was actually true. About 50%, at least, of the patients had significant changes within a 2 to 3 month period. Now here's what was really key. The key was that unlike our drugs and unlike our previous therapies, they didn't have to remain on the therapies for the rest of their lives. The actual receptor site had been altered, and we won't get into the molecular chemistry, but had been altered significantly enough that they had resolution of their symptoms, and they were done. Well, that was a hard one, but a very happy one. Because in the old days, I used to say, gosh, we could treat a schizophrenic easier than we could treat somebody with OCD. And intuitively, that seems counterintuitive, right? Schizophrenia, this huge, amazingly complicated, patients hearing voices, da-da-da-da. Oh yeah, we can take care of that. Somebody with OCD just has to have everything right all the time, lined up. You mean that was harder to deal with? Absolutely. Well, that was about 2 or 3 years ago. And we do physician training in Australia and around the world as well. We got all excited and we were telling the Australians about this, and Dr. Walsh had spoken to them about it, and they were also starting to use it, and we were just very happy and content. And now we're walking around with our chests puffed out and extremely proud of the fact that now we had a grasp on OCD. Well, as science would have it, there was a new element that came out within the past couple of years, actually the past year or so. And we found out we could even more fine-tune this process by using this particular element for individuals who were over-methylated and would have OCD-type symptomatologies. Now, remember before we said that most of the OCD issues were under-methylated? So the question was, well, what'd you do about the over-methylated? Or maybe even the normally methylated individuals, but who still had OCD-type tendencies? Well, now, this element came forth, and we went, you're kidding me. I mean, we just got used to this other thing out there, and now we've got this new key. And once again, the research is coming out of the American Journal of Psychiatry. I love it, because when people ask us, well, now, doctor, we're not quite so sure about this here thing. Now, I've not heard about this. I've been in this field for 30 years, and I just want to be real sure you know what you're talking about. Do you have any studies on this? I just kind of look at these lovely doctors and I say, Doc, when was the last time you read the American Journal of Psychiatry? Because in last month's issue, it talks about this and the studies that have been done for the past. All of a sudden you get these quiet physicians. Oh, well, I've been so busy with my practice, I just haven't had time enough to really kind of get to that particular one. And but I'll make sure I read that journal. Now, what would you say this element was again? And what was the journal article? It said, well, it's called D-series. Not the cycloform, but the D version. And when we talk about D and L, it usually means which way sort of the molecule faces. It changes the chemical properties of the molecule. Okay. I won't get into a whole lot of molecular chemistry, but the idea here is that when you start to quote the sources to the physicians that they're used to, they kind of change a little bit, because now they're asking you, did you do the research or did someone else? You say, not only did I not do the research, it comes out of the very journals that the organization that governs what you do in your practice has not only blessed, but identified and put forth in written form for you. So here you go, Doc, go read about it. Then come back and talk to me.
Is it D-serine? D-S-E-R-I-N-E?
Yes.
And is that an amino acid, Dr. Mensah?
It is.
Okay.
It is. It's an amino acid. It's one of the basic building blocks with a slightly different conformation than what's used. When I say conformation, that molecular shifting. Molecules are very interesting. There's a D for right-facing and there's an L for left-facing. So if you sit this way, you get one effect. You turn around this way, you get a totally different effect. Did you know, by the way, the two sides of your face are not symmetrical? Tara, you probably know this, but did you guys know that? It's an interesting story. If you've ever seen them do this on TV, I know we're deviating for a moment, I gotta tell you. It's like two sides to one person. And what they did was they took the picture and they superimposed an exact replica of the other side of your face based upon this image. And there's a totally different person. And then they took the other side and superimposed it, and you saw yet another different person. You go, wow, both of those are me, but they're two totally different things, two very different looking people.
But funny, we know which side is best for taking pictures.
We do. We do. As a matter of fact, my daughter, she's a PhD candidate, God, I always say that, at University of Maryland. And she always takes a picture, and she always has a certain pose.
Right.
I say, why do you use that pose? It doesn't show your beautiful face. And she says, oh, Dad, I'm this way, and I don't look good that way, and da-da-da-da. I just think I look better this way. I said, listen, you look fine. Just take a straightforward picture. Don't worry about it. But the same thing is true for our molecules. If they are in this format, they function this way. So it's not that you can just take the product with the name. You've got to have what we call the right isomer that's working. Okay, and these advances not only come with OCD type behaviors, but with a lot of other behaviors as well. We're seeing that these new amino acid based constructs, that by the way, the world of pharmacology and the drug companies are jumping in the bits to get to, and they're trying to pharmaceuticalize these elements. These are the waves of the future. Why do I say that? Primarily because the more we study, the dumber we get. The more intelligent we are, you're realizing that we're really stupid to begin with. Okay? And we're seeing that where we started, looking at DNA, and then leaping to chemistry, and then leaping to pharmaceuticals, and ignoring the chemistry. Now we're looking back at the chemistry, which has led us back to now to DNA. What we're seeing is that these methyl groups affect DNA expression. The molecule that gives the orders to make the proteins, the neurotransmitters, the hormones, these molecules are affected by processes such as methylation. Adding methyl groups changes the balance in the structure, which now actually can shift whether you make the right protein, the wrong protein, whether or not that protein is active fully, partially active, or not active at all. Now, if you know anything about chemistry, chemistry is one giant domino effect. And that's really the way our systems work. You hit one thing, it leads to two other things, leads to 20 more things in both different directions, and before you know it, you've got 600 different biochemical processes that have been working. But what happens if you have the wrong domino to start? You move down the wrong pathway. The key behind methylation is that it is part of the early domino cycle. Having too few methyl groups puts you at a disadvantage. So the right proteins, neurotransmitters, hormones, etc., if they're not made properly, they may not be activated properly either. So you may get partial or no function. So now, let's just say, for example, back to our start-stop analogy. If we've got norepinephrine that's present, and we don't have enough methyl groups to turn it on, maybe there's that fire going in your building. And you're sitting in your room, and you say, whoa, there's a fire there. Maybe I should get out. Maybe I'll sit here and think about what's the best route to get out. And maybe in a few more minutes, I'll really conceive of whether or not that smoke that I'm breathing in, that I'm starting to choke, is really doing any damage to me. That mechanism to get up and go at the instant is not there. And we know in some dire circumstances that can mean the difference between life and death. Instant, not functioning properly. Now, we've been talking about a bunch of things. Let's get back to OCD. Let's get back to some of the things we really sort of wanted to talk about with regard to things like rituals and hoarding and how this can be helped. We know now that in terms of treatment, there are new therapies available that have shown great success. Okay, you can't simply go just and pop these things. You still need to be tested. You need to ensure that you've got the right chemistry so that the right approach can be taken. And that's what we typically do. Now, when we're looking at some of the challenges, what I call the macro level here, we're seeing that, well, okay, what really affects my life? And it's different for each one of us. It may be living with that person. How do I live with my beloved of 20, 30 years, who now is so obsessive? And they may have obsessions, but no compulsions. But what do you think about, honey? Well, I'm still thinking about my shoelace. It's not tied. Why don't you tie your shoelace, honey? Well, if I do, it'll get fixed, but what if it happens again? And then we start to ruminate. We start to focus. It changes the interaction capacity, the interactive nature of our households. This is the part that's really hard, addressing these issues. And why? Because even after we've taken care of the chemical aberration, we still have to worry about the behavioral side of this. What we see typically in the old days of treatment with regard to OCD type tendencies involves usually some pharmaceutical agent and usually cognitive behavioral therapy. Okay. Now, as we've sort of addressed the pharmaceutical side, we'll just call it CBT, cognitive behavioral therapy is still very, very important. And why is that? How do we learn anything, really? And how do we sort of put it into memory? Well, some folks would sit around and ask, how does Michael Jordan, if you remember who he is now, LeBron James is around, how does Michael Jordan instantly know how to shoot the ball with the right height, speed, accuracy, and distance to make that shot? He doesn't sit around and think about it and draw a map and make calculations. He just does it. Well, it's a reflex arc based upon practice. The brain solidifies a pathway from this point, vision, to this point, moving the arm, to this point, moving the hand, to this point, moving the fingertips. All those complicated areas are brought into one cycle within fractions of a second. And the more he does it, the deeper this pattern becomes. It's called embedding. Okay? So what are we saying here? Even after you deal with the chemistry aspect, we've got behaviors that have become extremely embedded by a cycle of brain patterning. We have to undo that cycle, and that's still a very important factor in many individuals who have OCD-type tendencies. We may be able to eliminate the actual root cause, but now what about the ancillary issues involved, which are really sort of these patterns that have been created in the brain? We have to work to unpatternize them. Okay? What's the old saying? If you do something for 30 days, you'll create a wonderful new habit or a bad habit for yourself. Now, if you consciously try to undo what it is you've been doing or work in therapy for a decent period of time, you can really sort of get comprehensive improvement of the condition. So, a lot of verbosity, a lot of technical terms, but what I really wanted to share with you were a few basic things. Number one, what we thought was not testable before is testable. What we thought was not treatable before is treatable. And what we thought was a very good element to support the treatment, which would be things like behavioral therapy and other therapeutic modifications based upon that, is still key, useful, and important. At Mensah Medical, what we like to do is to practice what we call comprehensive medicine. It's not throwing out the old, it's reevaluating the old with a new key, a new focus, a new lens. It's taking the new and looking at how this can be incorporated, looking at whether or not it is of realistic benefit, and we're not basing it on fluff, hearsay, or what the latest Tribune article has to say. Or I hate to say it, but even what Dr. Frank Oz is saying. By the way, I have a lot of respect for Dr. Oz. But the key here is it rooted in the science? And that's the key piece that many of us don't really understand. because many of us are still focusing on what seems to be a nutrient and nutrient therapy, basically like we treat nutrition. By the way, the dosages and concentrations we use, you couldn't possibly eat your way towards. It's like you would have to, it's that old saying on television, you'd have to eat 30 bowls of total cereal
Right.
in order to get the equivalent of 50 milligrams of zinc that we're giving you in this capsule. Okay, this is what we like to call Neutraceutical grade therapy. We create these paradigms that are battling genetic tendencies, genetic tidal waves that throw off your chemistry, that therefore throw off your symptoms. And you have to have a huge, huge wave blocker in order to hold back that tidal wave and that tide. And that's what we're doing. We're literally now understanding that what we're doing is affecting DNA expression. And that's a very, very important thing. Because as we figured out what we're doing to help the battle, the question comes back full cycle. If this is what we're doing to create the change to help individuals, what actually happened to cause it in the first place? So now we start thinking about the field of embryology and how brains develop and how we develop from next to nothing in terms of size to this oftentimes between 7 and 8 or 7 and 9 pound individual that's given birth. And then as they develop from there, what happened that this person even had the tendency to develop OCD? Because if you remember that stat from 1990, 2.1 million people with OCD, well, what about the other 298 million, or is it 297 million people who don't have it? Why do these guys have it and these guys don't? Well, we're seeing in the field of epigenetics that things that happened literally between day 16 and day 22 of pregnancy are creating these tendencies towards these disorders. We're seeing that anxiety, depression, schizophrenia, autism, ADHD, OCD-type behaviors, all these, Alzheimer's, believe it or not, are all epigenetic in nature. Meaning, during that time period, there's a vulnerability present that changes in the womb environment literally are creating that domino effect that's changing the lives of individuals horrifically. The person develops autism. That is an epigenetic phenomenon we've discovered. So what happened back at that point in time? Here's where we're dumb again. Okay, we can't pinpoint, we don't know, because who on earth knows they're pregnant at day 16? Now, there are some interesting women, by the way, who said, I knew the moment I was pregnant, and they were right. They could go back to da-da-da because there was a strange reaction that they felt. They had a sense that something was different. But even then, they could not control what was happening in the womb in totality. It could have been walking by, ionizing radiation you didn't know about. You walked outside. It could have been a sound wave that may have hit. It could have been too much of a certain nutrient in your system that changes DNA. By the way, well, we know there's methyl, by the way, which is very important in terms of methylation. There's also other elements that are, shall we say, the arch enemy of a balanced perspective of methyl groups. Folic acid, by the way, don't we have every pregnant woman take folic acid, okay, in prenatals? Now, that's a very important element to use in prenatal development, okay? And that's because you want to make sure brains actually develop. But we have to start to question as a medical community how long we want to give these types of multivitamins during pregnancy. We know the first 3 months are key because that's when brain development is occurring. But why do we now have individuals taking these supplements all the way through pregnancy and beyond, and it's in the breast milk, and we're still exposing infants to this? The reason I bring it up, at the DNA level, folic acid steals methyl groups. So if you are already low in methyl by your own DNA design, now we take an extrinsic variable, put it in that system, and it makes you even more undermethylated. Okay? So now, once again, our DNA, our proteins, our neurotransmitters, our hormones are being constantly affected because the initial molecule that hadn't given any orders yet is thrown off. Even worse, it's heritable. The changes that occur in the DNA molecule we're talking about what we call markers. Okay, and these are points that say, okay, produce me, cut that out, do this, produce the changes for neurotransmitters, etc. Those changes that are made can be passed on to the next generation. Unlike, and we call it epigenetics because it has to do with the way the environment of the womb has affected the DNA molecule. And its environment and genetics. That's where we get epigenetics. That can also set you up for a tendency. You may have a tendency to be the most stressed out individual, but if you live out in the woods, and I hate to say it, in some isolated part of, I don't know, Tennessee or North Carolina or Ghana, West Africa for that matter, and you don't meet anyone else, you may never know you had any stress in your life. But now put in the environment of, say, corporate America, and you're now middle management CEO somewhere. Now the stressors get to you and you start to drink. You may start smoking. You may do a lot of these irregular behaviors. You may get OCD. All these things going all the way back to a DNA molecule, the wrong balance between methyl groups and folic acid, or methyl groups and phosphoryl groups, or some other biochemical element. I said we're dumb here because we don't yet know the exact nature of every single imbalance that we're seeing and what's causing it, but we've located the fact that it's here, at this point, at this level, where we're starting to see these challenges. Who knows? This is what we know today. Tomorrow we may know a whole lot more, and we'll see how much brighter and smarter we get, only to find out how much dumber we were originally. Okay. So that's really sort of the construct under which we're working. We're looking at testing what is now treatable, whereas a lot of people in this country and in this world don't realize that it is treatable. But that's the beauty of having cutting-edge researchers that you work with, and the dynamics of discussion, treatment, testing, and evaluation all going on at the same time. And that's what we do. So, blah, 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 blah. I talk a lot. Let's have some questions here.
If you want any cookies too, you can just pass them around too. Do you want to slide that over? I think, maybe Dr. Mensah, you could address a little bit about, in your folders is actually a handout called Biochemical Individuality and Nutrition. So that kind of really classifies some of the most common biochemical imbalances. Just so you can use that as a resource, because today was a little bit more narrow. But maybe you can talk a little bit about how we see patients here and what kind of testing we do and how often we see someone.
Sure. What we do is we have a very specific paradigm. And in that paradigm, we have to have an in-person evaluation. We get discussions about, well, can't we Skype? This is the 21st century. Can't we do that? So, well, you know what? Can I really hear your heartbeat from through the television screen? And the answer is, of course, no. At least not yet. So we have an in-person visit with our nurse, with us, excuse me. The first part of your visit involves meeting with one of our nurses. They do a comprehensive paper evaluation where they ask very specific questions that are related to symptoms and can often point to biochemical tendencies. And they usually last somewhere between 30 minutes and an hour, depending on the patient. Then you meet with the doctors, that's me and my partner, Dr. Bowman, and we sit down and we tend to talk for about an hour to an hour and a half. I always say you kind of leave about 3 hours of a window between the time you arrive and the time you leave. Then we order very specific labs that are geared towards the chemical imbalances that are present. And then basically the patient gets to go home. They'll go to a given LabCorp facility, get the labs drawn. We'll then get the test results, and then we'll take all that data that we had, paper data, the in-person evaluation, all the discussions, and we correlate that with the test results. Each one of the chemical tests that we order has significant symptomatology that's associated with it. And some of them are overlapping and similar. But that's where all this testing comes in, so we can kind of tease everything out. Then we put together a very specific nutrient protocol that's involved, that is targeted. And this is the difference. We don't do guesswork here. This is not about a shotgun methodology. We know what every single nutrient that we're using does. We know why we're using it. And we know why we're using the concentration that we're using. And it's different for everyone because everyone has a variability in imbalances. They can be mild, they can be moderate, they can be severe. Where our dosing is very much based upon which category you fall into, what your symptoms were, etc. We also have two levels upon which we kind of put together nutrient supplementation. One is to treat the chemistry. The other one is to help the symptoms. What's key here is that you don't have the pharmaceutical side effect profile. Okay? Because we are using nutrient therapy, it's what your body would normally use anyway, just a lot more of it. And it gets directed into the right areas because of the combinations and the patterns we use. So we don't get things like, weight gain or fatigue or all those things that literally stop people from using their pharmaceutical medications. One of the biggest problems that men have in this arena is taking a medication that inhibits their sexual capacity. They will drop that thing faster than Jack Spratt could eat no fat. Okay, can't say I blame them. Okay, but we don't have those effects. Our biggest side effect that has been seen consistently, our biggest side effect has been improved health. And that's because the body basically multitasks. The body and the brain use the same nutrient elements. It's just that the body is greedy. So it will take up as much as it gets, and then whatever is left over, the brain might get some, outside of sheer glucose metabolism. Well, here's the challenge. What is a typical American diet like? Horrible! And if we're not getting, under normal conditions, the kind of nutrients that we need for our bodies, do you honestly think our brains are getting what it needs? No. Our brains are full of drugs, half the time. We have our morning coffee, caffeine stimulate the old brain. We have a donut, or we have a McDonald's something, whether it's Egg McMuffin, or and don't get me wrong, I've done all this except the coffee thing, so I'll be honest. But I also know how I feel afterwards. And a lot of these foods are depressants. Food is a drug. Surprise, surprise. And we know it deep down, internally. If we want an upper, what do? We go for the carbs. We go for the caffeine. Okay. If we want to be settled, well, nice little glass of wine. Settle us down real nice after a hard day. Honey, I got home, let me have my martini. Okay. So we have to recognize sorry, I got a little bit off track here. But the very foods that we eat can affect our cognition. Foods rich in folates, by the way, very, very difficult for an undermethylator because a lot of times they don't know that these foods are rich in folic acid. But it's now stealing methyl groups from that person who's an undermethylator, and it seems like you're typically working with a healthy diet at that point.
What kind of things do you have the folics in?
Dark green leafy vegetables. Kale, soy proteins for the vegetarians, lutein, broccoli, spinach, and don't get me wrong, raw spinach. I used to watch Popeye. Loved raw spinach. Didn't like the way it tasted, but I knew it was good for me. Or so I thought. Until I realized, you know what, if you don't know what your chemistry is like, how can you really determine what is good for you to eat? It goes well beyond the type A diet. It goes well beyond the eating for your blood type, or eating for your this or eating for your that. Nowadays, I like to put out there, eating for your chemistry. Okay. The real answer behind, doctor, what's the best diet for me? Well, there is no one-size-fits-all diet for everybody. Yes, there's some people who may do very well eating like rabbits. Okay? The over-methylators do great on vegetarian diets. But I feel for the under-methylator who philosophically believes that they should live like a rabbit because they're always wondering why they're depressed. They're always wondering why they don't function as well. Well, it's because you're actually eating diametrically opposed to your chemistry. And this is where I say the smarter we get, the dumber we are. Who was right? Didn't great-great-great-grandma say, eat a balanced diet so you don't get too much of one or too much of the other, but a little bit of everything? They were right. So diet also becomes an element that we talk about as an adjunct to nutrient therapy. Because now that we know if you're an undermethylated and overmethylated, if you've got high copper, not a good thing. That can cause anxiety, that can cause depression, can cause panic disorder, can cause fatigue. There isn't a system in the body that is not affected by high levels of copper, in particular in conditions like postpartum depression, postpartum psychosis. Dr. Walsh actually did the research on this and found that 85% of women with these conditions were copper toxic. Now remember what Dr. Mensah said before. Why bring it up if you can't treat it? We can treat that. Okay. But even more so, we can help educate patients to say, here are foods you probably don't want to have too much of. I hate to tell you, chocolate's on that list. If you're a copper-sensitive person.
Even the dark chocolate?
Even the dark chocolate. Rich in serotonin. Yummy, yummy, yummy. But boy.
I'll go 2 days without chocolate.
Wow. We're going to talk about that.
2 days.
Well, and if we can go back a little bit to appointments, so the,
Oh, yes,
the
yeah.
patient, that's
I got
okay.
off track.
That's all right, but the patient will come in and have this initial appointment first evaluated by the nurse with a health history, extensive, a good hour to hour and a half discussion with you and your partner, Dr. Bowman. And then a telephone case manager is assigned. I shouldn't say telephone because if you do live in the area, it's okay to drop by. But a nurse will be your case manager who will kind of walk you through the process of when you get your targeted nutrient therapy, how to take it, where it's ordered. We order it through a compounding pharmacy so that it is tailored to your biochemistry, taking in other factors like allergies and height and weight, male or female. All those things are evaluated by the doctors when they complete that prescription. And then from there, you are now taking your program. We might have you start in slower dosages and move up. It slowly depends on, again, your chemistry and what the doctors decide. And then we usually just see you that one time. Usually we would touch base with you and want progress reports to find out how you're doing. And you can either fax them in or call us, or we will call you routinely. And this is all covered in that initial visit. And then in 6 months, we'd like to see you again to again retest you to make any refinements to see if there's anything else that may have needs a little bit more tweaking. A new program may or may not be altered, depends on what the nutrients therapy program that was initially prescribed, if it needs that. And then we usually see a patient just once a year thereafter. So I know when I introduced you all to Mensah Medical in the beginning, you can see now why we have patients from all over the world and all over the United States, because it's not that hand-holding that sometimes you would have to do if you had the flu or a virus or a disease condition. Oftentimes people then might have to need, and depending on what the doctors recommend too, the continuation with a counselor or a therapist to continue making those behavioral changes. Children on the autism spectrum may do well with applied behavioral analysis, which is ABA therapy. And then there's other things too that are in considerations that are supplemental but helpful in the process. And that's generally about how our patients are seen here at Mensah Medical.
Most of our conditions, or most of the conditions we treat, basically require time. And so there's no need to see a patient every week or every month. Now, sometimes there are a little bit of challenges that come up, and a patient would want to come in and have that discussion. There's no extra charge for that. We're talking about being part of a healthcare team. We're not saying we have the answer, and everybody else, no, you can't do what they're doing or doing this or da-da-da-da. No, we're saying, well, here's the chemical part. Now let's work on the cognitive therapy part. Now let's work on the dietary part. Now let's work at all the different pieces of the puzzle. Once again, comprehensive medicine is our goal. And putting all those things together, now we end up with a person who is where they should be on many levels. Okay? And there are guides along all those pathways. We have very good associations with different therapists that are around, and clinical nutritionists and so forth and so forth. So there's always a good referral base relative to people who are skilled in working with the pathological conditions that we work with. So it's not going out and finding somebody, well, you just do kind of nutrition, but what do you know about OCD? What do you know about this? Well, I don't know, but we can tell you that a good dietary plan in general is, don't eat kale. Okay? We don't work that way. The people we work with are specialists in the field of pathology, like we are. So we can help direct individuals to people who say, oh, you're an undermethylator. Well, let me print up the list of foods you don't need to eat. Here's some foods that are rich in the food elements that are going to be beneficial for you. So we kind of work in that fashion. We call ourselves a piece, or a significant piece, we believe, to the treatment of individuals to move them to that next level.
Another question people sometimes ask too is, do you have to have your nutrient therapy compounded? We recommend it because it would reduce the amount of capsules that one would take. However, I guess you could go and do individual supplements. It's sometimes difficult though to find it in the exact quantities that we want you to take it.
But let me tell you, this is a good topic, because there are some folks who really are so, I hate to put it this way, so OCD that they enjoy taking 22 capsules in the morning and taking 24 capsules in the evening. And they will look and take that one, look at it, put it in their mouth, take a sip of water. That's number one. That is their OCD. Okay? So we work with all types, as long as you can get it into your system. Okay?
Yeah.
That's the key.
Now, with my son, he's allergic to a lot of things, and one time I had it compounded when we were going to Pfeiffer, and he had hives after a week. We had just paid $200 for the stuff.
No.
So now we just go with the basics, and then we try for 3 months, 6 months, and then if it works okay and he doesn't have, a reaction, then we go ahead and compound it too. So
And-
anything new, we
And we
do
work with you
individually.
on that. It's very important for us to have those basic understandings, and there's so many people in today's world now that have, allergens of some sort, some sort of whatever, gluten, soy, corn. Some of those are the more common ones, dairy.
I'm actually glad you mentioned that, because that's why we changed our protocols from the way it used to be at our old institution to this format that we use now. Because people were getting their programs compounded immediately without having these questions asked, without assessing for allergies or sensitivities. And they would spend $200 to $300 only to be told, well, you've got to reorder a new shipment. And you spend another $200. We said, no, we're not going to do that. We're going to make sure our compounding pharmacy, that is the people we work with, speak to you first and try to eliminate every possible difficulty before they make that product. And even then we say, don't order 3 or 4 months yet. Order 1 month. Let's try it and make sure it works. And if it doesn't, we can have a hand in working with the pharmacy to fix it so that you get what you really need the right way.
And I'm sorry, you discovered that obviously gluten was one of your son's issues.
Oh, that's my other son.
Yeah, okay. Well, and people don't even know this, but that's like a filler in these nutrients. So it seems odd that why there would be flour or protein like that in a capsule, but there is. I'm sorry, your question.
What compound pharmacy do you use?
We use a pharmacy called the Village Green Apothecary in Maryland.
Okay.
It was tested by our research component, Dr. William Walsh, ever so brilliant Dr. Walsh, and found to have the highest quality product, one of the top 2 in the country. So we work specifically with them.
That's what I was wondering, because some of this,
Yes.
it's kind of vague in what they're doing.
Oh, well, here's the thing. Not only did Dr. Walsh test them, we've been to their pharmacy. We've seen their lab. We've seen the people who are there. We work with them extremely well. These folks don't make a move without our permission. So some of our folks who are a little bit on the perfectionistic OCD side like to control and manipulate their little programs, and they'll make a phone call to the Village Green Apothecary and say, I really think that I'd like to have that zinc level lowered a little bit. And would you please change? And I said, no, we cannot do that. We have to talk to the doctors first. You get a phone call. Dr. Mensah, it's Ben, and Mrs. So-and-so is requesting, and so we go take a look at Mrs. So-and-so's chart. And we say, absolutely not. or we say, you know what, Ben, that one is okay. Then they make the changes. So in order for us to help you, we have to make sure that we have quality products and the right products being given, and that somebody is not going to be able to make changes without our authorization. And that's another reason we use this pharmacy. They're really good in terms of working with us and our patients.
One of the things I know the title of this talk was iObsessed, the many forms of OCD.
Yes.
And, I think that almost, and I don't know if you want to comment about this, or
Absolutely.
anyone here around this table, since we're having kind of a round table discussion on this particular topic that I'm going to bring up, but, I think society to make so many demands on us today, and I'm thinking about just alone in 10 years what we do with technology, for example. Oh my gosh, it's mind-boggling. And how that's actually now contributed to this need to constantly be informed and stay connected. And oddly enough, it's not even like what we used to do, which was on the phone, but it's all the texting, and it's the computers and the Facebook and the Pinterest and everything else.
Yes.
And I'm wondering whether OCD is on the rise. And that when you think about the obsessions, I think that people have now with their toys, their technological gizmos.
And thank you for bringing us back to there's so much to this topic that we could literally talk for days, and we're trying to compress, but that's a very, very good question. And the whole point for me is very salient, because I can't stand what's happening to the interactive capacity of the next generation.
Thank you.
Our kids are dumb. And of course, our parents said the same thing about us. You may know more book knowledge than I do, young man, but the way you learn is not conducive. You would not survive if you were out there, and blah, 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 blah. Well, it's even worse when we're seeing our kids trying to find jobs in the workplace. They really don't know very well how to find a job because they can't communicate. They say, well, I applied online. I said, son, do you know that there are about 500,000 people applying for that same job online? Didn't I tell you to call Ed? Ed knows Sam.
Yeah.
Sam told me that if you called him, this is the way it was going to go. Well, yeah, I heard you, Dad, but the thing said, call or just rather do the thing online. I said, okay, you just sit there and wait. Okay, we're losing a lot of things that were basically common sense and learned by way of interacting with people. But here's the OCD component. Let's say you're a little bit predisposed to being an OCD type person, but you never had those symptoms. You don't have to worry about it. You don't have those exposures. Now we've got devices that literally reward you second by second with stimulation. Okay? So now you become drawn into that interaction. Oh, my computer. Oh, my cell phone. Oh, my iPad. And I have to tell you, sometimes we need it for work. There's a lovely joking picture that I took with my partner, Dr. Bowman, where in my office I had my left hand on one computer, my right hand on my cell phone, and my left ear had a telephone device while I was looking at yet a fourth piece of machinery. And while I was laughing about it, I said, I've actually done at least 3 of the 4 of these in real life. And I realized that's the kind of arena that we're living in now. We're multitasking, multi-texting, multi-everything. We can't do anything just sort of with one focus at a time. First, it started with our video games and our kids. The stimulation in a video game requires this much of a focus. So we were talking about ADHD and its development through these kinds of things. But now we're getting the idea, well, we're on these pieces of technology so much. What if we're not on that piece of technology? Now we become obsessed with wondering, are we missing something? Why do I have to check my email 3 or 4 times? Well, because other people are making it so. You've got to do that. As we become unhooked from our physical offices, from our physical spaces, from our physical interactions, we're getting increasingly more dependent on our electronic devices for the same information. Does Johnny love me? I've got to check my text to see if he called. Did I get that job? I got to check my email. And if you don't, you miss out on something majorly important sometimes, and you find out the next day. So these things are literally helping to create, or I don't know, I shouldn't say that, helping to support those tendencies that now move us in the direction of real pathology. What happens when you take the devices away? What happens when you go on vacation? How many movies have we seen where the critical piece, and I have to say I was watching Lifetime the other day with my wife, and it's true, Amanda's watched Lifetime, and the focal point was a workaholic wife who could not stay off of her cell phone, could not stop looking at texts, even at Thanksgiving dinner. And I sat back and I said, now here is an important piece that we're seeing. We're becoming so tuned in, and forgive me, I'm not your generation, because we've got plenty of them just like you. We're now being so drawn in that we have a hard time doing without. We're still looking over there. We're still trying to check our information when we're supposed to be having fun. How do we even manage to go to a health club and put away our phones in a locker while we're supposed to be exercising our bodies so that our minds may remain functional? One of the most difficult things that I try to talk to parents about with their children is you have to learn that you are actually in control. That's a hard thing for many parents to understand. Well, no, I'm changing his independence. I want him to be more reliable on himself and so forth and so forth. And I say, well, ma'am, then why are you complaining because he spends most of his time doing this if you don't ever check him on that? I say, you know what? Here's an interesting idea. And I love this commercial on television where the dad wants a family gathering and he goes out in the backyard and he unplugs the electrical outlet. So everyone thinks that, Dad, we lost power. The neighborhood has no power. And he pulls down the drapes. And so he said, well, we're just going to have to sit around and talk for a little while. and then something happens and they're like, wait a minute. Our neighbors have power. They realize the plug was out. But this was a dad taking the initiative to recognize that in order to bring back the community, we have to sometimes just say no to the devices. And with our kids especially, they're so glued into these areas that we have to literally call timeouts. My own partner, Dr. Bowman, I have a 4-year-old, you guys know Chloe, but on the way back from a Disney trip, Dr. Bowman introduced Chloe to Angry Birds. I imagine everybody here knows what Angry Birds is by now. If you don't, it's a lovely little game that you can get on your iPad, and it's driving me crazy now. But she loves it. She says, goes to her mom, I want to play Angry Birds. And her mother say, okay, yes, my darling, here you are, go right ahead. And I'm going to make mom the bad person for this moment because dads are not where the heavies. And I said to her, no, you can't play Angry Birds. Go do something else. I said, no, because you're only 4.
Yeah.
I'm not going to train you to sit on the computer all day long.
Right.
But what's interesting is that she will go to her mother, who, by the way, is a computer analyst, something. And she's on the computer a lot, and she'll say, close the computer. Close the computer. And she's saying, listen, Mom, I want your interaction.
Yeah.
I want your focus. I want your time. And we have to be more cognizant, not just of our children, but of ourselves. I will share with you one of my own personal foibles. I am a microphobe. I don't like microorganisms. And every now and then, so in terms of washing your hands, in terms of keeping some individuals would say that I'm perhaps a little bit OCD at that point, which I'm in denial about, I say proudly. But what I recognize is that anyone can move in that direction given the right set of circumstances. So I have what I call my own personal timeout, where I purposefully get my hands dirty, and I won't wash them for a few minutes anyway. Okay? Or I will simply not do the constant element of the hand wiping, okay, with those lovely little towelettes and so forth.
Right.
Okay, you can create checks for yourself if you're aware, if it's early enough. Or that might be something to suggest trying with your family or your friends. And say, listen, what would happen if just for once you actually didn't pick up that device? You didn't carry that phone with you. You didn't do this. You didn't do that. What about if you told your kids, don't do that? I see kids in cars, they're sitting there texting. I'm like, back in my day, we simply had to talk for the 4 hours that we were in the car and da-da-da-da-da. So you can say, time out, stop. Okay. We talk about hoarders, and I do want to touch upon this for a little bit. That's a huge, huge pathology. Does anyone not know what hoarding is, by the way? Anyone not seen that show on television?
We're
Okay.
talking about hoarding, like
Whatever it is.
People that are
Yeah. They go to the
Absolutely.
extreme.
They go to the extreme. And why? Because, unfortunately, their chemistry, and here's where we're coming full cycle, their chemistry was now interacting with a concept, and there was reinforcement around that. There was a certain level of gain and a certain level of relief based upon the behavior, based upon the concept, and based upon the action fulfillment of that idea. So now we continue to do it. And if there's a little that's good, a little bit more is better. If a little bit more is better, then even more is awesome. What about the fear side? A lot of times fear is a critical element that's involved in these OCD type behaviors. If I don't check that door for the third time before I go to bed, someone may burst in there or it may just explode, and my family will die. So I've got to check the door 3 times before I can go to bed. Now, this is where it's not just the chemical piece, but a great deal of cognitive therapy also becomes very beneficial. Perhaps let's try this where you just check the door twice, okay, instead of 3 times. And maybe next month we'll try, and I'm just throwing this out there, I'm not saying this is the actual therapy, but maybe next time we'll try just 1 time to check. Because that's reasonable, that's logical. And let's see what happens. Okay. Very hard to do. The habits that have developed because of the chemical bases are extremely powerful. And it takes a great deal of work and patience to move out of those cycles. But you need both elements to try to help any individual move through those conditions.
Does anybody else have any more questions?
What
It is
is, what is
8:30.
the cost of coming here? For this 3 hours that your initial?
The initial visit is $750 to come here, but that does not include your lab testing. And the reason why it's separated out is because oftentimes your insurance may be covered the testing, so you can. And we use LabCorp as primarily our major test centers. And again, depending on your insurance company or health insurance, you may have some coverage on it.
And I
And
want
then-
to.
I'm sorry, go ahead.
Well, it's not a fee-for-service kind of a facility. So you don't pay $750 as a fee for coming in for the day. $750 is kind of like your initial health club membership.
Yeah,
Okay.
right. Yeah.
And then 6 months later, you'll pay half that for the next, if you want to call it, session. So consider, say, $750 for 6 months. What does that really come up to?
$750 would not be covered by the insurance, is that what you're saying?
Most likely-
750 could or may not. We don't know your insurance
Oh,
plan.
okay, so it would be submitted to your insurance.
Yes,
but it could be
actually what we would do is we don't have an insurance processing department here. Unfortunately, for a lot of medical practices or even anybody that's involved in healthcare has found that can be a huge drain on their practice to have that kind of people studying and knowing how to submit. So what we do is because these are MDs, they will give you a sheet, a procedural sheet that shows your diagnostic codes, and you submit that into your insurance.
Okay.
And I would say roughly 60 to 70% of our patients get some kind of coverage.
Okay.
Again, depending on your insurance, but you have to remember we see ages anywhere from 2 years old to 82, as I always say, because we do have an Alzheimer's program as well. So again, Medicare, Medicaid probably won't cover it, but other insurance plans might.
Okay.
And then your nutrient therapy may be covered. Again, you're using Village Green Apothecary is mostly the choice that people want to do is have it compounded, and they are awesome at working with the insurance companies and submitting it for you to see if there's any coverage on that.
Okay.
And then remember, and I think Dr. Mensah started to talk about that, and maybe that isn't a good analogy with a health club. It's like that membership. It's not really a membership, but it covers that period of time. So all your calls to us, emails,
So your testing is on top of the 750
Yes.
and then the compounding.
And the
on top of
compounding.
that.
but your all
But no,
your
those are not
calls and
ours, though.
emails.
Hmm?
Those are not ours.
Yeah.
No,
The
no.
testing is done by a separate
Separate.
institution, and we don't control those fees.
And same with
nor
your
do we do the
compounding.
compounding.
Okay.
We write the prescription, and it's like Walgreens. We write the prescription. They're the ones who charge you for it.
And then it's half the price for the follow-up visit. So follow-up visits are very reasonable. And it was at $275. So, and if you are seen at our outreach clinic, there's an additional outreach fee. Only because we do take the team and we literally fly there, take hotel rooms, and set up the hotel rooms in a patient format. So if you have friends or relatives in other states that we travel to, I could talk to you later about that, about the cost structure on that. But we're really very cut and dry. It's very easy. In fact, I can tell you, as a person that's worked with Dr. Mensah and Dr. Bowman for years, not only here but at their former place, former practice, I have more people tell me it's the best, whatever, $700 or $750 or $800 they've ever spent, or $1,000 if you want to round it up for lab testing, because we say, it's true. I think we help you zero in exactly what you're needing to respond quickly. And our doctors, by the way, are willing to speak to the primary care physician, to the psychiatrist, to the psychologist, to be a part of your healthcare team or for your loved one's healthcare team to really help that. And again, those are not, you're not going to get a consultant's fee on that. I mean, this is all comprehensive in that initial fee.
I've got to tell you.
Jumping out to me too is if you have a really complicated situation, this one-time testing, it sounds like then you're going to be able to know how to best address everything. Because I think as a psychologist over here, I'm thinking, well, gosh, my patients oftentimes, are really complicated. It's like, well, I'm anxious, I have some OCD, I'm depressed. They could come see you, and really then they're going to get this great workup, and you're going to be able to treat all of that, with kind of all these supplements all at once.
Correct.
And it's not going to be that hit or miss thing you were talking about earlier.
Correct.
Like, well, here's a little this medication, try this. Well, now there's a new trial all the time. It looks like you're going to really be able to kind of package something.
That's exactly what we do. That's a nice way of putting it. We create a package, okay, and that big package is very specific. It's like Christmas. If you got the doll, if he got the doll and you got the racetrack, something was wrong, okay, on average. So, yes,
I
packaging.
think Dr. Mensah said too that with the nutrients, because my son is 22 now, or will be soon. He's aging out of the school system. That's why I go with 22. But we've been doing it since he was 6, and he's been in special ed, throughout the years. And when I see some of the side effects that some of his friends have had from all the crazy things that they've been put on, they don't realize all the side effects. That the growth can be stunted. They can have all kinds of digestive issues. They can have all kinds of side effects. And I just have never gone to any medication with my son or other.
Well, and the other beautiful thing, and we didn't really address it today because the topic was a little bit more specific to the OCD, but we do have a public informational seminar coming up later in November on anxiety and depression. And I really encourage people to attend, even if you all want to come back to it. We are, sometimes people have to hear and digest all this information, because we're going to talk a little bit more specifically on other disorders like pyrrole disorder, for example, and the needs that sometimes some people have to have an antidepressants also with us and complement, and that we're able to target which antidepressant will work the best because of your biochemistry. And that is phenomenal. We get a lot of psychiatrists just very enthused about this, because now they can take away that Dr. Mensah mentioned earlier, that bit of hit and miss thing.
Right.
Now we can say, because of this biochemistry, our research has showed us that these SRIs are more effective or can work in a small dose or whatever, and it makes a nice complement. And Dr. Walsh, who we're associated with from Walsh Research Institute, he and Dr. DeVito, not only a colleague of Dr. Mensah but also Dr. Walsh, are planning to go to the American Psychiatric Association next year at their May annual meeting in San Francisco to present on that very same topic. So
I could have said it better myself.
Any other questions?
Well, one thing I do want to say, my wife told me this yesterday. She said, do you know, I heard that now some doctors' offices are going to charge you if you ask questions. And I heard, and then I said, what are you talking about? If you call and ask a question, if you are asking more than a certain number of questions during the course of a visit, you will be charged more. And I said, you are kidding. I didn't know this. I said, that is abominable. But what they're saying is that really time is money for them. Okay, and the more time they spend, less money the insurance companies are going to da-da-da-da-da, blah, blah, blah.
Well,
And
that's
what
right.
we want to share is that that's not how we operate. The time that we spend with you is just the time here. You know what happens when you go home. We've got to analyze all this information and all the data and so forth and so forth. And that's very labor intensive. But what we want to provide is comprehensive care, and we can't do that in a 5-minute visit. Okay? So the way that medicine is moving, which really disgusts me as both a primary care doctor and a specialist, our goal is supposed to be to help people. It's not supposed to be to collect money. There's got to be a balance in there,
Right.
but this is moving in the wrong direction.
But all
And that's a
the-
direction we're not moving in.
The whole country's moving there. It isn't just the medical field. It's the banks, no matter
It
what you
is.
go to, it's the same thing.
It's another
But
way
in
to make
talking
money.
about that, I went to a doctor one time, who literally never took his hand off the doorknob.
Oh no.
And I just said, what's it going to cost me for another 5 minutes of your time? And the man just stopped dead in his tracks. I don't think he realized what he was doing. And he calmed down and he took his time. I don't think he realized. And I was ticked off. I mean, I wasn't coming
True.
back.
Yeah.
It was one of those cases.
There's
but-
lots of those horror stories out there.
yeah. And
How do you handle compliance in terms of if you're working with somebody,
Yeah.
how do you know that they are compliant with what you're doing? Or do they have to have full buy-in, which challenge that I dealt with is that the person's probably in denial that there's anything even going on. So the idea of agreeing to submit to
Here's the difficulty.
some sort of assistance.
If they don't want to do it, we can't force them. If they only want to do it 50% of the time, we want to make sure that everyone understands this is not a multivitamin that you can take today and forget about it for the next 3 days. You have to have greater than 85 to 95% compliance for effect. When you get below a certain point, it doesn't matter. You can take it every day, but if you're not taking the right amounts or whatever have you, you're not going to get the appropriate effect. And so we let you know that up front. Now, and I've had a schizophrenic patient whose family members have called me 2 days in a row. And that's what we do. We'll talk to family. But they said, well, she's not willing to take this. Would you please talk to her? I said, now, normally we don't do this part. But I said, okay. So I spoke to her and I said, listen, you need to take this supplement. Will you take this? Da, da, da. She said, yes, I will. Well, but I want to take it in a liquid form. I said, great. So we'll say, order the liquid form. Then I got another phone call. It's a different family member for the same patient. She doesn't want to take it. I said, the unfortunate part is that we can't force her to do this. So that's the real difficult piece. And I'll tell patients, I'll tell family members, before they ever come here on the telephone, if your child, if your family member is not going to be compliant, this is the wrong place to come, and we will not accept you. Okay. I try to be as blatantly honest, and people who manage to get here with the wrong idea behind them, I have said, well, here's your money back, or simply don't pay us. This is not right. We can't help you.
Right.
So if we accept you as a patient, and you are in any one of these rooms here with us, it's because we feel we can help. But compliance is key. And that's a hard one, Skylar. It's a hard one. If they're not willing to do it, if they're in denial of their condition, that's an uphill battle that probably I would actually start with perhaps a therapist to help talk them through some issues and some things.
Try to move them toward accepting
Exactly.
maybe help. But
When
yeah,
they can accept that they need help,
Sure.
now the door
Yeah.
opens to other arenas.
Or sometimes it's a little less intimidating to talk to a nurse, and we have excellent nurses here who are very good at least starting to help initiate the conversation. They may state that yes, they need to see a therapist or someone first, but at least to start it. And sometimes it feels a little less intimidating if you have to talk to the doctor or come for a visit. So let us know how we can help in any way. Well, everyone, thank you very much for your time.